Is I've written upper 4 and lower 4. What about extracting upper 4 and lower 5? It's okay. What I mean here is extracting in the upper and lower branch. Extracting upper and lower premolars, that's the same letter. Sometimes you can extract upper 4, lower 5, you can extract upper and lower 4, you can extract upper and lower 5s, doesn't matter for us. Why? Because we are following mechanics based on reduced force and okay, so this is for years we've been observing. If I extract either the 4 or the 5, doesn't matter. As long as I can apply 150 grams of force to the nitrile closing coils, from the molar to the keyhole, that's a wire called a keyhole wire, we do a mechanics on that. If I apply 150 grams of force, the force is very small for the molars to come forward. Only the anteriors will go back. So with this knowledge, whether I extract 4 or 5s, I can still get a good predictable space closure. Okay, so it's a very good question that you asked. Does it make sense? So it's okay if you don't. If you just choose upper 4, lower 4 as a plan and extract the 5s, the treatment plan will still be the same. So I'm trying to tell you. In the MOS, it doesn't show upper 4, lower 5s because we are using the same plan if it's extracting the 4 or the 5s because of measured force with nitrile closing coils. Okay? Any other question? So that's how I want it to be. In case something is not very clear in your mind, something I spoke that's not making any sense at all to you, or you just missed it, just stop me. Okay? We can speak about this again. Otherwise, I'll just keep going. Real often falls short of ideal. Okay? You will not get this all the time. I've been doing case ortho for years now. Do you mean every single case of mine looks like this? Although I love it if it looks like this, my objective when I start a case is to make it look like this. But there are so many things that go around it. Number one is the patient's cooperation. Remember, no matter how skilled you are, if the patient doesn't cooperate, you will not get it. Can you tell me other situations where you will not get ideal results? Missing teeth, excellent. Anything else? Skeletal malocclusion, we just spoke about that. Anything else? Bolton's discrepancy. Have you heard of Bolton's discrepancy? The amount of tooth marks present in the upper arch and the lower arch has a specific ratio. When you have peg-shaped lateral incisors or larger central incisors, you may have something called Bolton's discrepancy, where the ratio will change. When the ratio changes, again, you will not have ideal finish until you add some IPR and correct the Bolton's discrepancy. Okay. Non-extraction simulations. Whenever your bite classification is class 1. What is class 1? The mesiobuccal cusp of the upper 6 occludes with the buccal groove on the lower 6. If you draw that line, those lines have to meet. If they don't meet, then it's either class 2 or it's class 3. Alright? Depending upon how much, it gives you simulation. 1.1. What is 1.1 in other words called? 1.1 simulation is your one wire technique. Just align the teeth and the treatment is done. That's 1.1. Okay? 1.1 is not suitable in a class 1 case. When would 1.1 not be suitable? Everything is class 1. Why can I not choose 1.1? If the patient's profile is becoming very, very protrusive. For example, my profile is good now, and I have a lot of crowding. I'm class 1. If I treat this patient non-extraction, what is going to happen to the incisors? They will advance. As the incisors advance, they will also procline. If they procline, the following things can happen. Number 1, patient's profile may become very, very protrusive, which they may not like. Number 2, the bite may open. As the teeth advance, they advance like this. The patient never had open bite. Now they start developing open bite because of too much of incisor advancement. So you may not like it. And third, the tissues are very, very thin in the beginning before you started the case. And you let the incisors advance, you will end up in gingival recession. The tissues may not like it. So when you have all of these considerations, then treatment plan number 1.1 will not work for you. Okay? If treatment plan 1.1 does not work for you, and you still want to treat the patient non-extraction, you have certain modifications that you can do. Modifications are done to reduce the incisor from advancing. What are the methods that you know which can reduce incisor advancement? Number one is expansion. If you expand the arch, the amount of advancement will reduce. This word expansion is being frequently misused because you will think, let me just expand the hell out of the case and treat this case non-extraction. This is called a non-extraction disease because every doctor wants to treat the patient non-extraction. Every patient wants to get treated non-extraction. Everybody is trying non-extraction, that's when you get non-extraction disease. What's the problem with expansion? Why can't I not expand in every case? Because the nature of bone in the upper arch and the lower arch is different. Upper bone is cancellous, lower bone is cortical. If I expand in the upper arch, the amount of expansion will be more. If I expand the lower arch, the expansion will be less because the cortical bone will resist the expansion, isn't it? If the cortical bone resists the expansion, you will have arch discrepancy. Arch discrepancy is upper is expanded more than the lower. You will have excessive horizontal overjet. It's a new terminology I'm introducing to you. What is horizontal overjet? Horizontal overjet is the space between upper and lower canine. Normally the upper canine and the lower canine will touch each other, like you see in this picture. Can you see this? Can you see this? Canines are touching. If you see a situation where upper canines and lower canines are not touching, it's called horizontal overjet. Write it down. It shows that upper arch is expanded more than the lower arch. Okay? Whenever the upper arch expands more than the lower arch, then you will not get a class 1 canine. You'll always get only a class 2. If you want a class 1 canine, then you have to tuck the canines back in so you can get class 1. Okay? That's the reason why we cannot just expand too much in every case. So how do we decide how much to expand? What is too much expansion? Depends on the case. If you see the start inclination of your posterior teeth is lingual, then when you expand in the case, you will get much more predictable expansion. Because you're really not expanding, you're just uprighting, isn't it? If my molars are out in this case, in this case you see all the molars are lingually inclined. Can you see it? If I expand in this case, the expansion is much more predictable. The expansion is more predictable. But if I have cases where the molars are already straight, those cases I cannot expand because I will get buccal tipping. Buccal tipping is the crown goes out, but the root stays in. What's the problem with that movement? You will have, you will have very high relapse because that movement is not stable. The rule in orthodontics is the crown always goes on top of the root. If you got the crown outside and the roots are still staying inside, then you will have relapse. When you do aligners in cases where you want to expand the arch, you have to always ask the lab to add 20 degrees of buccal root torque to the posteriors. I repeat, when you expand my molars are here, I'm going to expand, the crown is going to go out. I have to ask my lab, I want buccal root torque of 20 degrees. So the roots also can go out on top of the crown. Okay? But for that to happen, the gingiva in the posterior should not be very thin. Okay? So you have to look at the tissues. The tissues should be able to tolerate that amount of roots coming out. So all these are features of your clinical evaluation. And we have an evaluation form that we gave you. Remember the form we had traffic lights from green until red and yellow in between. On that page, it tells you, is it okay to expand? Is it not okay to expand? How do you decide that? Based on the tissues of your posterior feet. Okay? If expansion is not possible and you still have to treat the patient not extraction, you have to add IPR. How much IPR is too much IPR? Sorry?
Depends on your tooth shape.
Perfect. Well done. It depends upon the shape of the tooth. If you have teeth which have thick enamel, they are good candidates for IPR and you can do them more. If you have a patient with no enamel because of interproximal wear, you cannot do any IPR. Okay? But just to add a number, we consider 2 to 3 millimeters of IPR as a base average value. Okay? 2 to 3 millimeters is normal value. Now we have something called a non-extraction plan, and we spoke about this last time as well. 2 millimeters of crowding will give you how much of advancement of the incisor? 1 millimeter advancement. One millimeter of advancement gives you 3 degrees of proclination. As your teeth advance, they don't advance body, they will procline. Okay? This is how you calculate the amount of expansion and advancement a case can have. If you look at the start models of the patient or the start scan, you have to eyeball and calculate how much crowding the patient has. This just keeps coming out of experience. If I give you a few cases and ask you to guess, you will just learn to predict how much crowding the patient has. Say the patient has 8 millimeters of crowding. How much advancement will the lower incisors go through? 4 millimeters. And how much will be the proclination change? 12 degrees of proclination. Okay, this is how it usually happens. So I need to know what my average incisor inclination is. 90 to 98 degrees is the average incisor inclination. Okay, if I start with 85 and the patient has 8 millimeters of crowding. Okay? So how much will be the degree when I finish? 8 millimeters of crowding, you get 4 millimeters of advancement. 4 millimeters advancement, you get 12 degrees proclination. The starting is 85. 85 plus 12 is 97. I'm still within the range. If I'm still within the range, then the risk of gingival recession is less. Okay? Say the similar situation, my starting angulation is not 85, it's 95. Okay? Now what will be the finish? When I finish, it's going to go to 107. That is very, very proclined. So now I have to do something to reduce the advancement. Okay? So to add further calculation, lower expansion will reduce the crowding by 1 millimeter. Lower IPR can reduce by 2 millimeters. All of this, so if I have the same case, 8 millimeters of 8 millimeters of crowding, giving you 4 millimeters of advancement. If I add expansion, I can make 8 as 7. If I add IPR, I can make 7 as 5. This is how you calculate the lower incisor position. Okay? You probably need to have this written somewhere as a reference because that's how the software is designed. Okay? Now, for me to know if the recession is going to happen or not, what do I need in the front of the incisor? I need bone. If my incisors have to go forward, I need to see if I have bone present for the incisors to go forward. Isn't it? If there is no bone, then you will have recession. That is called skeletal resistance. If there is no bone present for the incisors to move, you classify the case as a high skeletal resistance. When you look at your simulations on your MOS, you will see the bone is somewhere here, but the incisors are present far ahead of the bone. You know that's not really possible. So the simulation shows incisors are outside the bone, then you have to go to the next option, 1.2. That is IPR with no expansion. 1.3, expansion with no IPR. 1.4 is expansion and IPR. Okay? That's the maximum you can stretch to treat the case non-expansion. If this shows you still the incisors are too much outside, then you must extract. Understood? This is how the simulations have been planned, and this is how you will decide what you want to do in the case. Any questions? Okay. When you have a class 1 case, it's casing, you have to now decide how do you want to close the space. You can either close the space with the incisors going back or molars coming forward. Both will maintain class 1 canal and close the space. How do you decide which one has to move? Profile. Excellent. Have you already attended the class or what? Profile is the way you decide. If a patient's profile is good, taking the incisor inside will worsen the profile. Alright? The incisors position is good, then you mesialize the molars, and that is called treatment plan number 1.5, which is called minimum anchorage. Minimum anchorage is keeping the incisors where they are. All the spaces present in the arch is closed by the molars coming forward. Is it possible to be done? Yes, it is. How do you control that? You have to use certain brackets which will not allow the incisors to go back. That is called anterior anchorage. In the upper arch, you have a bracket called the LI bracket. LI is lingual root torque. LI. An LI bracket digs the roots lingually. So when I move my, if you take a dog for a walk, sometimes you just pull the dog doesn't want to come, right? It's because it's pushing its leg into the ground, resists. It's exactly what an LI bracket does. It pushes the roots inside. So if you push the tooth back, tooth cannot come back because it is tightened tightly to the 19/25 wire. Then you keep applying the force. The incisors can't come back, so molars will move forward. That's called an anterior anchorage, which is achieved by an LI bracket in the upper, and the lower you have to use something called the SLI. LI over SLI incisor brackets are the brackets of choice when you want to close spaces with the incisors staying where they are and the molars go forward. This system is called anterior anchorage. The anteriors are creating the anchorage and the molars are moving forward. Okay? What's the difference between LI and SLI? LI is a O22 bracket. SLI is a O20 bracket. O20 is the size of the bracket slot in which your wire is engaged. Okay? Li is O22, SLI is O20. The smaller the slot of the bracket, less will be tipping, more bodily movement. Okay? So S stands for super. This is a lingual rooftop bracket, super lingual rooftop bracket. Okay? All these are specifications of POS brackets. So if you ask me, can I do this with MBT? The answer is no. You can't do it with MBT. Because MBT, when you apply forces, will not hold the incisors where they are. They will retract. So as they retract, the patient's profile will change. Understand? So which cases can I use MBT brackets? Which cases will I have to get this POS bracket? These are the considerations. When you want a minimum anchorage plan, you need something which will not allow the incisors to go back. You have to go use POS brackets. If you want to use, it's okay for me to retract the incisors, then you can probably use an MBT bracket. Okay? This is how you decide. Same thing if you have to use aligners for these mechanics, you have to plan something called sequential mesialization of posterior teeth. What is sequential mesialization? Your teeth will move like a train. You should not move all teeth together. So 4 moves, as the 4 moves it creates space between 4 and 5, then the 5 starts moving. And then space between 5 and the 6th, and 6 starts moving. When you do this with aligners, the aligner material will go in between your 4, 5 and 6s and push the teeth forward. That's the advantage of sequential mesialization in a minimum anchorage case. Okay? Or you could use a reverse pull headgear. That's an extraoral appliance. Reverse pull headgear is generally used for connecting skeletal class 3. But if I use a reverse pull headgear and take a rubber band from the headgear to the front of my face, and I can get elastics from here to the molar, will the incisor move? No. The incisor has no force at all, so the molars will move forward. Okay? These are the methods of doing minimum anchorage in a case. Make sense? All of this 1.5 simulation is enough. 1.5 means what? 1 in the 1.5 stands for class 1. But if you have a patient who has spaces and it's class 2, how would this change? If the patient is class 2, how would that change? This picture, what is the patient's malocclusion? Class 2, how much class 2 is it? 4 millimeters class 2. Minimum anchorage will be in the upper or the lower? To correct this, the lower should be minimum anchorage, when the molars have to come forward. But the upper should be maximum anchorage. So if the upper molar comes forward, the class 2 will worsen. Okay? So this is how it will change if you have a class 2 case. And similarly for class 3. So in a dental class 2, close spaces by moving the lower posterior teeth forward. Dental class 3, move the upper teeth forward. Okay? That's how minimum anchorage is done. This is the protocol for all aligner cases. I probably showed you this in the first seminar as well, but if you haven't, please take a picture of the slide. It's very critical because no matter which company you work with, if you can write a lab slip which is as detailed as this, you will get good results. Okay? The moral of the story is we don't want you to depend on the technician to give you the setup. If you can tell the technician what you want in your aligner setup, you would probably have a much more predictable setup. Okay? In aligner therapy, the more time you spend in your setup, the more successful your outcome would be. It says correct rotations at 1 degree per aligner. That's the rate at which rotations are predictably corrected with aligners. The linear moment is 0.2 millimeters per aligner. Okay? Level the marginal ridges. What does it mean? That means you have to correct the curve of speed. Okay? Buccal root torque on all the teeth that are expanding. Whenever teeth are expanding, you have to add buccal root torque. Why? Because you will have buccal tipping. Now you have to decide if this one needs to be applied to your case or not. If you had a case like this, would you add that line? No, because the teeth are lingually inclined at start. If I expand, they're just going to become uprighted. So I will not add that line. In cases where you have all the teeth that are straight in the start and then you're expanding, then you have to add 20 degrees of buccal root torque. Why 20 degrees? Because aligners will always underperform. If you ask for 20 degrees, you will get 10. So you ask for 20. Okay? Finish with uniform overjet on all cases. Finish over by the 1 to 2 millimeter. This is ideal intel incisor angle. All of this will assure that you will get class 1. Now this protocols are already applied with progressive aligners. So in Malaysia, luckily you guys have progressive aligners. When you work with progressive aligners, all you have to do is, please give me simulation 1.1. The moment you tell this to them, you will have all of this done. But in India, I don't have progressive aligners. So every time I have a case, I have to write all of this. So a technician knows what I want. Okay? If you notice, the first setup never has any IPR. Once you notice all of this, then once you see the first setup, if you feel you require IPR, then you ask them to add IPR at a place that you need. Okay? If you don't tell this to the lab, I can guarantee you the first setup will have a chunk of IPR. Some of you who have done aligners will see when they give you the setup for approving, they will have IPR everywhere. Okay? Now this is not POS talking, it's me talking. When I do IPR in my patients, I really like to do IPR in the anteriors. I don't like to do IPR in the posteriors yet, because I feel that you will destroy the contact area. Destroy the contact area, you will never be able to recreate that contact in the molars and the premolars. How many of you would like to do a class 2 restoration? Nobody, right? Hate it. Hate it. And I go for these class 2 composite master classes, and the guy who's speaking there, he's such a good artist. And he will show you some of his cases of deep margin elevation with all these different fancy bands and retainers, and he does a beautiful job to do it. And when you go back to your practice and you start doing it, it's a mess. The patient next day comes back, it's a sensitivity, it's breaking off, food is getting stuck. It's hate it. So what do? I just prepare a tooth, I take an impression, and the lab makes an inlay. And when they make an inlay, I don't have any of these issues. Do you guys do inlays? Just try Emax inlays. They last lifelong. As long as you have enamel, it works the best. Okay? But what I like about inlay is the lab is able to establish a perfect contact area between the inlay and the next tooth, because they're doing it outside the mouth. I find it hard to do this inside the mouth. When you do IPR in the posteriors, nature has this already done for you, and you will go break it. Really tell me, what's the chances that you will really get that contact area back again? It's very tough, number one. Second, it's a technique sensitive procedure. No matter what you use, you can use your burr, you can use your strips, you can use your disc. It has to be perpendicular to the contact area. If you have 1 or 2 degrees of angulation, when you do your IPR, you have destroyed your contact area. Okay? So the patient has to have a very, very nice mouth opening, so it can allow your disc to go all the way back between the 6 and the 7 to do your IPR. When it comes to anteriors, it's much, much easier, because sits in the front, you can see it, you can visualize it, the instrument can go perpendicular very easily and you will have less deleterious effect. Are you guys with me? But you will have setups where they will ask you to do posterior IPR. When I see that, I tell them no posterior IPR. Okay? Unless I'm doing something where I use alignment.